A very good evening to all of you, and wishing you all a very, very warm summer evening. So, today over here, we discuss a topic which doesn't seem to be rare, but is a rare diagnosis, and we will be speaking on familial hyperlipidemia. And today we are blessed because we actually have two speakers with us who are pioneers in the field and who will be discussing this topic. First, we have Dr. Professor Seema Bhargav, ma'am, who will be speaking on the lipid biochemistry, and she's a chairperson and senior consultant with Department of Biochemistry and professor at Sri Gangaram Hospitals. We also have Dr. Ratna Duapuri ma'am, though she needs no introduction, but still I have this pleasure to introduce her. She's chairperson, Institute of Medical Genetics and Genomics, lead Indian Undiagnosed Disease Program, Sir Gangaram Hospital. And I will not interfere in between. And I request all of you to please put your questions in the question answer box. And we'll come back with all the questions and discuss at the end of the two talks. And I invite Seema ma'am to please deliver her talk. Thank you.
Thank you very much, Dipanjana. And yes, it is a very warm summer evening. So I just wanted to, oh God, कुछ ना कुछ तो यहाँ पे गड़बड़े चलती है. Give me a moment, please. Yeah. Can you still hear me?
Yes, ma'am, you are audible.
Okay, fine. That's great. So despite having done this, I'm sorry, give me.
No problem, ma'am.
I'm sorry that my video is not working, but thankfully my slide sharing is working, and that is what is more important. And I'm trying to get my cursor, but I'm just not finding it. Where is it gone? Here it is, but then it disappears, and then it disappears, and it doesn't come. Oh, I don't know how to get this out. Okay. Yeah, here we are. So if I do this, this is the one that is, yeah. So, okay. Now I am with you. So is this a full screen mode for you?
You have to,
Dipanjana?
ma'am,
this
you
full
have to
screen?
do a full screen. No, ma'am, it's not
Yeah,
yet.
so in mine, it's showing a full screen, but let me see. Let me do it again.
Yes. Yes,
Now?
ma'am, it's full screen.
Okay.
Yes, ma'am. Thank you.
Okay. So good afternoon, ladies and gentlemen. And what I want to talk about is a little bit about the biochemistry of what constitutes the lipid profile and why it is important in cardiac disease. And I will, of course, talk about what the latest guidelines are, and also what, how they have come to be by applying the evidence that already exists. So all of us know that amongst all diseases, cardiac disease has the greatest burden of morbidity, and it is second only to cancer in terms of its mortality. They say that every 34 seconds, someone dies of cardiovascular disease. And in 2017, the statistics stated that 17.7 million people die every year from cardiovascular disease, which is 31% of all the global deaths. And in 2023, in just another 5 years, it went up to 19.8 million people. So what is the global prevalence? And this is the global prevalence, as is 7750 per 100,000 people. And in India also, the various regions have different prevalences. What is important to note here is that in 2016, CVD was the cause of death in 15.2% of the deaths. And within 4 years, it almost doubled to 28.1% in 2020. So that is the whole huge problem that we are trying to deal with and trying to assess early, to diagnose early, and that Dr. Ratna will talk about. When we started our work in Gangaram Hospital, actually much after that, around early 2000s, we decided we need to have a biological reference interval that is specific to our population. So we enrolled about over 250 controls and over 220 coronary artery disease patients. And what we found is that all of them had similar mean lipids, whether it was total cholesterol or HDL or LDL, triglyceride was slightly different, or LPA. So what this was a high cholesterol, a low HDL. And all of these mean values were very close to the biological reference interval, the upper limit of the biological reference interval, except for HDL, in which it was close to the lower limit of the biological reference interval. And all these things put together constituted that you had a high cholesterol, low HDL, high LDL, high triglyceride, high lipoprotein A, and all of it constituted an atherogenic milieu. Give me a half a second. He's trying to put me on, but I'm not getting on again. Sorry, I'm interrupted by my IT people who are trying to get my video camera on. It's all right. If it doesn't get on, just let it be. We'll just carry on. So what happened now? So this was in the early 2000s. ओहो, अब कहाँ पहुंचे आप? आपने मुझे कहाँ कर दिया? हाँ, okay. Recently, that is just about 2 years ago, we again decided that there have been so many changes in lifestyle, so many changes in dietary habits, so many changes in terms of early diagnosis and management of cardiovascular disease. Maybe the statistics have changed. So we decided to do a retrospective analysis of over 4,000 normal individuals. We took their lipid profile, but to our surprise, it was exactly like it was 20 years ago, 25 years ago. So this is something that is inherent in our population. And that is what we came to. And a similar observation was made by the cardiologists of India, who came together as the Cardiology Society of India, and they also decided to deliberate on this and see how should we go forward, what should we do, and what are the things that we should test and why. So they came up with their CSI clinical practice guidelines for dyslipidemia management. And within that, they also gave the guidelines for testing of lipid profile and for what should be done at what time, which I'll come to soon. And this was headed by Dr. Jitender Pal Sani, who is the head of cardiology in our hospital, Sir Gangaram Hospital. So what exactly does the blood really contain? It is the total cholesterol, which is comprised of high density lipoproteins, low density lipoproteins, and very low density cholesterol. So all of them put together make total cholesterol. In addition, these are the cholesterols, but in addition, we also have triglycerides and lipoprotein A. What is the importance of each one of these? I'll just come to that. So all of you know how the endothelial cell injury, but the first step in any atherosclerotic process is injury of the endothelial cell. And that releases cytokines, and then there is a cascade of events which ultimately leads to the subendothelial deposition of the oxidized LDL particles, which causes the atherosclerotic plaque in the blood vessel. And so internationally, there have been guidelines as to how do you manage and how do you assign risks and what do you look at. And amongst the demographic details, but some of the demographic details, this is one where they take age, blood pressure, diabetes, smoker, and apart from that, the two biochemical factors that they take in is low density lipoprotein cholesterol and high density lipoprotein cholesterol. So only LDL and HDL, nothing of total cholesterol, nothing about triglyceride, nothing about LPA. Why is that? So we know that the LDL particle is the main culprit in that it is what actually forms the plaque. But what makes it form the plaque is also important. So normally it forms the plaque. We know that it causes atherosclerosis. What is its relationship with the hepatocyte? So in the hepatocyte, there are LDL receptors, which receive, or rather which have a recognition for the apolipoprotein B100, which is attached to the LDL. So with the HDL we have apolipoprotein A, and with the LDL we have apolipoprotein B. And B100 is specifically the one that is more atherogenic, and we'll come to that also why it is so. So the moment they attach to the LDL receptor, it causes disintegration of the whole LDL molecule. And when this process is disrupted by, say, non-recognition of the LDL of the ApoB100, which may happen with any polymorphisms, then that is what it takes. Now, in addition to the LDL, you have these endoplasmic reticulum LDL receptors. In the hepatocyte, there is the endoplasmic reticulum, which produces the PCSK9. And the PCSK9 is what actually competes with ApoB100 on the LDL receptor. So this also prevents disintegration of LDL. And if there is, if ApoB100 are if there are any polymorphisms in that strand of lipoprotein, that also produces atherosclerosis. Sorry, it also produces an increased level of LDL in the circulation. So, and that is why we have PCSK9 inhibitors also. That is one of the treatment modalities these days. What about the HDL? We said only two molecules were addressed, the LDL and the HDL. So it was earlier only the LDL was very well known. Later on, we realized that the HDL had had the advantage that it too was equally important in that it prevented atherosclerotic processes. So it had antioxidant processes, anti-inflammatory properties, anti-thrombotic by its antiplatelet effect. It prevents platelet aggregation, and it also causes activation of the C protein, which again prevents platelet aggregation. It also enhances the reverse cholesterol transport, and it is a profibrinolytic. So therefore, HDL was equally important. But what about triglyceride? Why is this not important? This too is important because whether your triglyceride comes from your intestinal absorption of exogenous triglycerides and gives you chylomicrons, or whether it is synthesized by the liver and gives you VLDL particles, both are acted upon by lipoprotein lipase, and they give you cholesterol remnants, which are highly atherogenic, and therefore they are also, and that is why cholestyramines are used in therapy, because they inhibit lipoprotein lipase. That is now, but earlier, despite that, the guidelines, that international guidelines, do not include triglyceride in that first slide that I showed you, where LDL and HDL were the only ones that were taken into consideration. What about lipoprotein A? Oh, what about apolipoprotein B? So we find that apolipoprotein B is associated with all the chylomicron remnants, and all the VLDL and LDL and LPA particles. But chylomicrons and chylomicron remnants have ApoB48, whereas the remaining three have ApoB100. And these are the ones that are the most atherogenic, because it is the actual apolipoprotein which is recognized by the LDL receptor on the hepatocyte. And therefore, any gene mutations, as I said, would result in their non-recognition by the LDLR and an increase in LDL in the blood circulation. So let's talk about the LPA molecule, which has been known for decades and decades, but is gaining importance, and is more evidence is being evidence is being generated regarding its role in atherosclerosis. So the LPA contains of an LDL core with an apolipoprotein B100 and an apoprotein A. So there are two apoproteins attached to the LDL core, which makes a lipoprotein A molecule. And we know that this is very atherogenic and causes atherosclerosis. What this ApoB100 does is, as I've already told you, it attaches to the LDLR receptor. The LDL receptor causes disintegration of LDL. And that is how the LPA molecule is associated with increasing LDL levels in the bloodstream. So ApoB100 polymorphisms will prevent this process. And that is how LPA contributes to atherosclerosis. But what about the other part of it? Now let's come. So the thromboplastin A has a plasminogen binding site onto which plasminogen binds, and this causes, stimulates the fibrinolytic process where the thrombus is dissolved. And under normal circumstances, we have the apolipoprotein A attached to the lipoprotein A molecule, and this we normally also have a plasminogen activator inhibitor, which does not allow the plasminogen to overact. So if there is too much of plasminogen, the inhibitor will come into play and will not allow bleeding to happen. Otherwise, thrombolysis may happen, but bleeding can also happen if there's an excess of plasminogen. So what does now the apolipoprotein do? Apolipoprotein A specifically, it competitively binds to the site that is meant for plasminogen. So it prevents plasminogen from binding, and therefore it slows the process of thrombolysis or prevents it altogether. At the same time, it also further activates or stimulates the plasminogen activator inhibitor. So it has a dual mechanism of action by which it causes thrombosis. So we talked about atherosclerosis by the action of ApoB100, which is recognized by the LDLR receptors on the hepatocyte. And now we're talking about thrombosis because of the action on the plasminogen receptor as well as the plasminogen activator inhibitor, both of which are impacted and cause an increased thrombotic activity in the bloodstream. So both ways, LPA therefore has dual effects, and therefore it is strongly atherothrombotic. I would not say just atherogenic, it is atherothrombotic. So when there are apoprotein A polymorphisms, that is when this action will not happen. And that would be actually good for the body, and there wouldn't be a prevention of thrombotic activation. The chromosome of LPA is, the gene of LPA is seated on chromosome 6 on the Q arm, the long Q arm, from 25.2 to 26.3. They're saying 25.3 here, but that's not correct. 25, it's up to 26. And what are the types of polymorphisms that can occur? Typically, it is well known for the Kringle 4 repeat polymorphisms. And whether it's a pentanucleotide repeat polymorphism or SNPs in the LPA gene, or splice site mutations or nonsense mutations, or even unknown variants within the Kringle 4 repeats, all of them can impact our atherothrombotic process. And therefore, any sort of polymorphism in the gene of this one molecule, which has 3 basic components, can cause atherothrombosis. Of course, there is also its association, as you can see here on the right-hand side of the slide, the genetic diseases like familial hypercholesterolemia, which Dr. Ratna will be talking about, and familial defective apolipoprotein B100, or even AB like lipoproteinemia, or LCAT deficiency, that is lecithin cholesterol acyltransferase deficiency, which is required to actually metabolize the cholesterol. And LPL I've already talked about, for which cholestyramine is given. Another apolipoprotein, which is known to be associated with the LPA activity, is apolipoprotein A, but it is yet not very clear how they interact. And in view of the importance of LPA, there is an ongoing international multicentric double-blind case control trial called the Horizon study, where the role of pelacarsen is being studied in the reduction of major cardiovascular events. And this is on basis of the fact that pelacarsen reduces the action of lipoprotein A up to 92%. And it is still underway, and probably next year they will be sharing their results. So then what should the lab do? What should be the time of sampling? Should we have a fasting or a non-fasting? Is there any diurnal variation? There are newer thoughts about this. Earlier, it used to be that we had to have a fasting sample for lipid profile. But later on, we realized that only 15% of the cholesterol that is circulating in your blood is actually from your diet. The rest is endogenously synthesized by the liver. So therefore, we find that there is no variation in HDL irrespective of the time or the fasting state. There is a minor variation in LDL and LPA and what they call the clinically non-significant variation. But in total cholesterol, there is a 15% diurnal variation. It may happen with time of day as well as with fasting or non-fasting. But there is one molecule that is definitely impacted, and that is the triglycerides. There is a high variability of triglycerides in fasting versus non-fasting samples. So then what should we do? So the recommendation is that we take a fasting sample is not required, but if the triglyceride in that non-fasting sample is more than 400 milligram per deciliter, then you must repeat it with a fasting sample. Or before you take the sample, if you take the family history and they say they have a history of hypertriglyceridemia, even then only a fasting sample should be taken for that particular patient. What do you do for LDL? LDL has been traditionally, for many decades, it was only by calculation. You did a total TG versus divided by 5, and then you subtracted the HDL and the VLDL from it, and you got the LDL fraction. And there were many more equations came along the way. That was the Friedewald's equation. But many more equations also came along the way, and they were better and better at estimating the LDL, the actual content of LDL. And many of these are even recommended by the international biochemical societies for non-fasting samples. But the gold standard remains the direct estimation of LDL. There is nothing to beat the direct estimation. Where this facility is not available, you may use any one of the equations depending upon which works for you. There is these days a lot of talk about non-HDL cholesterol, and it's that simple. That's just total cholesterol minus the HDL cholesterol. And you just need two parameters to actually calculate this. And they say that this non-HDL cholesterol includes all the atherogenic components. So it'll include VLDL, it'll include LDL, it'll also include the probably some part of the LPA, not all of it, but some part of it. So they say that it is easily calculated, so why not do it? Because it's just a calculation. You don't have to do an extra test for it. You have already done total cholesterol and HDL, you do that. The other thing is that there are many subjects who have a normal LDL, but they have a high non-HDL. And this subset of patients who have highly atherogenic LDL particles, they get missed often if you have not measured the non-HDL. Also, doing LDL alone is not a very accurate way of assessing cardiovascular risk prediction, because nowadays there is a high incidence of metabolic syndrome, and LDL is often increased in all these subjects. So whatever you are medicating, whatever medications are being given to the patient for their cholesterol levels to be reduced, all of them act upon non-HDL targets. So therefore, it makes sense to have a baseline value of non-HDL also. So what should you do for diagnosis? Should you do just total cholesterol, HDL, and triglyceride, and that should be okay? No, that's not good enough. Or should you do, because what about LDL and what about LPA? But if you do only those two, that also is not good enough. So basically, the recommendations of the international recommendations as well as those of our Cardiological Society of India is that you do all of them: total cholesterol, HDL cholesterol, LDL cholesterol, triglycerides. Lipoprotein A is something that does not change with diet and does not change over the years. So therefore, doing it once at the first instance of sampling a patient for lipid profile is adequate. If possible, an EPO-B should also be done, and that is the recommendation internationally as well as nationally. And EPO-B 100 should definitely be measured if there is a high suspicion of cardiovascular disease or if there is a history of familial hypercholesterolemia, which Dr. Ratna will be talking about. Sorry, Ratna, I'm putting a lot on you. For follow-up then, do we need to do everything all over again? Or would just one of these suffice? No. What we need to do is all of these, but not the LPA and not the EPO-B 100, because these are two factors which do not change with time. And because when you are managing a patient, one of these molecules is going to be the target of that of the lipid lowering drug, and non-HDL is something that you still have to estimate every time that the patient comes for a follow-up. So therefore, you should do a total cholesterol, HDL, LDL, and triglyceride. These four things when the patient comes for a follow-up. And this is the recommendation of our Cardiology Society of India, who used 20 years, more than 20 years data and their experience of treating patients to be able to come to this conclusion. They collated all of that data that they had. And this is how they came to this conclusion. What they recommend, the same Cardiology Society of India, is that before you actually decide whether your cholesterol levels are correct or not, you must know how to assign yourself to a risk category. Are you a low risk person or a moderate risk person or a high risk or a very high risk? So these are the demarcations of low risk when there is no risk factor. Moderate risk is when there is one CVD risk factor, along with a family history of dyslipidemia or central obesity, or a family history of young heart attacks, or smoking, or hypertension, or diabetes. A high-risk case is that who has diabetes and has one more risk factor, like hypertension, or chronic kidney disease, or central obesity, or dyslipidemia, or familial hypercholesterolemia. And a very high-risk case is that who already has evidence of blocked arteries, irrespective of all the other facts, whether he has diabetes mellitus or not, and whether he is a smoker or not, or whether he has tobacco or not, whether he has hypertension or not. If he has proven blocked arteries, he becomes a very high-risk case. And anyone who has an LPA above 50 is considered a high-risk case again, because it increases the risk of heart failure, cardiovascular disease, as well as aortic valve disease. This is the recommendation of our Cardiology Society. And what they say is that once you have assigned yourself to a risk category, now you decide what should your goal for each of the parameters be. And these are the category-wise, the category risk-wise goals. And as you can see, whether in case of HDL, triglycerides, and lipoprotein A, the goals are the same, irrespective of the level of risk. All HDL should always be more than 40 in males and more than 50 in females. And triglyceride should always be less than 150, and lipoprotein A should always be less than 50. This is a goal for achievement after you have started a patient on low Or even if you haven't started them on lipid lowering drugs and they come to you for the first time and they are assigned a particular risk, then they have to look at this. When it comes to LDL and non-HDL, the goals are different. So their goals are the same in low and moderate. LDL has to be less than 100 and non-HDL has to be less than 130. In high-risk cases, they have to maintain their LDL below 70 and their non-HDL below 100 milligram per deciliter. And very high-risk cases have to maintain their LDL below 55 and their non-HDL below 85. So what they have recommended is that all of this should be there on your report. So what our report constitutes, I'm sorry, I don't have a copy of it here. It constitutes the upper 1/3, includes the actual lipid results, the total cholesterol, HDL, LDL, triglyceride, LPA. And then with those results, we give the international biological reference intervals. After that, we give them a batch which says, assign your risk category. This part of it appears on the report. And after that, we have this table there for them to assess what their goal should be. And our suggestion has been, and we have actually circulated this to all the societies and to all the cardiologists and all the biochemists in our country. We have tried to do that. And our main idea is that what the cardiologists say, that there is that lone physician who is somewhere there in a far-flung area and he's not up to date with everything. If his lipid report comes along with these recommendations, it is so much easier for him to treat the patient appropriately and adequately, and at the same time tell them where they lie in terms of risk. In addition, ApoB 100, if it is done, ideally in moderate, it should be kept under 100, in high-risk cases under 80, and in very high-risk cases under 65. This is the recommendation. So the rest of it is the recommendation that's international for the risk categories. ApoB 100 is what our cardiologists have recommended for the Indian population. So therefore, to conclude, the guidelines for testing, interpretation, and management of lipid profile, especially in the context of cardiovascular disease, is constantly evolving because knowledge is changing every day and we are adding more and more to what we know about it. And they may differ for different populations. As you know, the Indian population is more prone to cardiovascular disease. And I didn't show you that slide. There is, we are 20 times as prone to cardiovascular disease as the Japanese, 6 times as prone as the Chinese, and 3 times as prone as the American population or the Western Caucasian population. For initial diagnosis, a complete lipid profile along with LPA and preferably with ApoB is ideal. And for follow-up, parameters of the lipid profile to be tested should be selected on basis of those that were abnormal on the first testing and the parameters that the medication is targeting. And of course, as I said, non-HDL is a necessary inclusion. Establishing the level of risk, having done the lipid profile, establishing the level of risk, especially by estimation of lipid profile, must be on basis of the most recent guidelines with respect to age, gender, family history, and population. And when lipid profile is normal and there is a family history of hypercholesterolemia or hypertriglyceridemia, we want to encourage the whole family to get the lipid profile done, which again, Dr. Ratna will be talking about, so that there is a timely identification of risk and we may start medication as early as, well, I won't take it away from Dr. Ratna. This is your area, Ratna. You'll tell about that. And I come to the end of my presentation. Thank you very much. And I'll unshare my slides.
Thank you so much, ma'am, for the wonderful insight. Would now request Dr. Ratnapuri, ma'am, to please give her deliberation. Thank you.
Thank you so much for that excellent introduction. into this webinar, Dr. Seema, and for making my work very easy. Are my slides seen?
Yes.
Yes, ma'am.
So I'm going to talk on a very specific topic, and that is familial hypercholesteremia. And we have now understood that this is a common inherited cause of premature coronary artery disease, typically associated and recognized by an elevated low density lipoprotein cholesterol. That's the LDL cholesterol. It's an autosomal dominant genetic disorder, predominantly of lipid metabolism. And the key thing why we need to create awareness is that this is significantly underdiagnosed. And it's important to appreciate that untreated, by 50 years of age, 50% of the men would have a coronary artery disease event, and 30% of the women by 60 years would also have a coronary artery disease event. And the reason is really that it is known that deposition starts, in fact, after birth only and in childhood or adolescence. So, therefore, if you pick them up early, this is one of the most um, fruitful disorders to treat because you can prevent premature death. Now, how do you recognize familial hypercholesteremia? There are many of these criteria, but the ones that we typically use is the Dutch Lipid Clinic Network, the DLCN criteria. And you can see that it includes a family history, and you can see the scores on the right-hand side. So either you have a first-degree relative with a known premature coronary event or a vascular disease, men less than 55, women less than 60, or a first-degree relative who has an LDL cholesterol which is above 95, right? The second part in the family history is the presence of a first-degree relative with tendinous xanthomas or an arcus familialis, which I am showing to in my subsequent slides, or in children less than 18, an LDL cholesterol above the 90 percentile, and these are more relevant and therefore have a higher score. In the clinical history of the person for who the criteria is being recorded, the person himself or herself has premature coronary artery disease or premature cerebral or peripheral vascular. So any cardiovascular event which is atherosclerotic. In physical examination, the presence of these tendinous xanthomas or an arcus cornelialis before the age of 45. And then these are the LDL cholesterol levels. And you can see that anything above 190 milligrams per DL start getting higher scores. And last but not the least is the presence of a functional mutation in one of these three genes, which are known to be associated at present with familial hypercholesteremia. And if you have a total score of more than 8, it is definite FH, and this is just based on these criteria. Or 6 to 8 probable FH, 3 to 5 possible FH, and less than 3 unlikely that it is FH. What is the prevalence in India? Now, generally in the population, it's not uncommon. As you can see, it's 1 in 250. And anybody who has a familial hypercholesteremia has a tenfold increase of an ischemic heart disease and a 24 increase of a premature IHD. The true prevalence in India is not known, but there is a study, which you can see the reference below, where they screened 4,000 individuals and found definite FH based on the lipid values to be 0.1%. And within this cohort, 90 patients who had a high LDL cholesterol, 4.4% of them were definite FH as per the DLC criteria, and 15.5 were probable. And they also saw in the next study by Dr. J.P.S. Sani et al. From Gangaram that in a cohort of premature coronary artery disease, 15% were diagnosed to have definite or probable FH based on these criteria. So these 15% are actually preventable CAD if they were identified early. And this data is also comparable with that from Actually, the study from Australia is the one where they have looked into similar parameters with comparable data. And so I think it's important to understand that this is not rare, but it is an underdiagnosed disease. And there are many gaps in physician awareness for screening, and hence the need for webinars like this. Now, coming to the inheritance pattern of familial hypercholesteremia, this is a typical autosomal dominant degree. You can see that this is the individual. You can see the lipid values, and there are multiple other affected members in the family in an autosomal dominant pattern of inheritance, with a 50% risk in every generation in the offspring of the person who has the same disorder. On the other hand, we also have an entity which is referred to as autosomal dominant homozygous FH. Now, typically, we know that autosomal dominant disorders are heterozygous because only one allele of the pair of that specific gene is mutated and can cause disease. So, because FH is common, it's not, uncommon, so uncommon to have two partners who have autosomal dominant heterozygous FH. And when they get married, their children have a chance of inheriting both the mutated alleles of the gene and having a homozygous familial hypercholesterolemia. What is the relevance of all this? As you can see in this table, these are the three children with homozygous familial hypercholesterolemia with mutations in both alleles of the gene, which in this case is the LDLR gene. And you can look at their triglycerides and the LDL cholesterol. And at this young age, they already have xanthomas. Whereas the parents who have heterozygous have slightly lower values compared to their children of the lipids. Beyond the autosomal dominant, we also have what is referred to as oligogenic familial hypercholesterol, where patients who have the disease have very high cholesterol, LDL cholesterol, which in this case you can read as 509, because of three mutations in two genes. In this patient, there was a triple hit, two mutations in the LDLR gene. These are the mutations, one each inherited from the parent, and one mutation in the PCSK9 gene, which was also inherited from one parent. Her siblings, who only had the PCSK9, did not have a very high level of LDL. In fact, it was 50 and 54. Whereas the other sibling who had the variant in the LDL had a value of 100. And the parent who had variants in both the genes had higher levels compared to the other parent. So these sort of things are now being understood because this is not a very common mechanism of inheritance. We also have one gene that causes autosomal recessive familial hypercholesteremia, and that occurs because of mutations in the LDL RAP1. What's the clinical phenotype? We've already talked about premature cardiovascular disease. It usually occurs in the fourth or the fifth decade in the heterozygous FH, but with the homozygous FH, it occurs much earlier. It could be an ischemic cardiac disease. It could be involvement of the aortic valves as well as calcification that Dr. Seema has already alluded to. We also have inflammation of the aorta causing, and there's also peripheral vascular disease. There can also be a phenotype as a result of cholesterol deposition in the skin. And as you can see in these pictures, there is xanthelasma deposition here under the skin and the eyelids. There is this arcus. These are lipid depositions along the tendons, in the hands, in here, Achilles. This is like really a tuber because this is in homozygous phenotypes, which are much more severe. It's like tuberous xanthomas as well as plantar xanthomas. In homozygous, this is again, you can see these are large number, huge of these with early coronary disease. Now, just coming to a case, and this was work done by Dr. Nitika Zetia as a part of a PhD, well published in multiple journals. She worked in our department and at the hospital on familial hypercholesteremia. You can see that this is a 63-year-old gentleman who's got ARCUS, and he had his first MI at 37 years. The level of LDL cholesterol at admission was 304. He's been on statins for cholesterol management since then. And another family of a 30-year-old who has homozygous mutations in the LDLR gene. You can see the multiple xanthomas over the dorsum of the hand, around the achilles, as well as the ibis, which is there at 30 years. And these xanthomas were seen as early as 13 years of age with a very high LDL cholesterol. What is a differential diagnosis when you come, when some patient comes with these reports? It could be primary genetic disorders beyond familial hypercholesteremia. It could be a polygenic hypercholesteremia, which I'll come to in a minute. Secondary hyperlipidemias, which are very important to exclude because these are more common than these pure genetic or polygenic forms of hyperlipidemia. When we come to the genetic understanding of familial hypercholesteremia, the most common form is the heterozygous autosomal dominant familial hypercholesteremia, which occurs because of mutations in ApoB, LDLR, PCSK9. On the other end, there is homozygous familial hypercholesteremia, which occurs because of mutations in the LDL AP1 gene, or it could be biallelic variants predominantly reported in the LDL. I've already alluded to the allogenic, where you could have more than 2 genes with variants because of which the patient is symptomatic and has higher LDL cholesterol. But you can see that a large percentage, about 40 to 50% of patients, do not have mutations in these 4 genes, and we'll come to it. Now, this is just a diagram to show what happens when there is a mutation in the gene. You can see that this is the LDLR receptor on the surface of the cell of the hepatocyte. This is the lipoprotein C particle with the ApoB that's recognized by the receptor. There is endocytosis and then recycling of this. And this is the role of PCKS9 in normal functioning. What happens is that if there is a mutation in the LDLR gene, the LDL cholesterol does not bind to this because here the structure changes, and therefore there is accumulation of LDL cholesterol in the circulation. If there is a mutation in the ApoB gene that causes a dysfunctional ApoB protein, again, the binding to the LDLR receptor is limited, and hence there is accumulation of the LDL cholesterol. These mutations are usually loss of function. They impair the functioning of the gene and formation of the protein. On the other hand, the PCSK9 gene variant usually causes a gain of function, so it acts much more and it limits the recycling of the LDL receptor because it causes degradation of that receptor. And because the receptor is now, there are fewer receptors on the surface of the hepatocyte, the LDL cholesterol increases in the circulation. Now, this is again work by Dr. Nitika in identification of the gene variants in the most common gene, which was the LDL. This was in an era when single sequencing was the norm. And so therefore the first gene to be, because this was the most common, there used to be a sequence, this used to be a sequence, and you can see here, this is a heterozygous mutation that is reported here, and this is homozygous in the child. Now, I already mentioned that these are the three common genes, the LDLR, the ApoB, and the PCSK9. In the previous years, nearly a decade ago, the LDLR gene was sequenced, the PCSK9 gene was sequenced, which has 12 exons, the LDLR 18 exons. And in ApoB, because there were 29 exons, it was very expensive to do Sanger sequencing. Only two common variants in the gene were looked at. However, with newer technologies, life has become easier. In one platform, you could just target these genes on the next generation sequencing panel. Mhm. For a patient, look at all these three genes at one go. And this is how it is. For example, this is a patient with the LDLR gene variant, which is a heterozygous gene variant. Once this is confirmed on the next generation sequencing, then Sanger validation is done. And more importantly, to evaluate other risk members in this family, as you can see here, you just do Sanger sequencing for that variant. We do not have to do next generation sequencing. And you can identify the members who are at risk and others who are not at risk. And this becomes very important. So what is this is data from India, published data from India. And in 245 patients in 6 studies, the dominant mutations were identified in the 3 genes for FH. These are the other genetic hyperlipidemias, and there is this homozygous FH. We still have a large number of patients, 37%, where the variant is not known. And so where are we with that? This is now the era of polygenic risk scores that are estimated looking at multiple SNPs within the genetic structure of the individuals and quantifying their burden to understand if the polygenic risk score is high or it's low, which again predisposes them to familial hyperphagia. And you know that individuals who have monogenic FH with high PRS are at a higher risk of uh, the associated risks. And of course, like all genetic disorders, there could be other genes that are not indicated. So the most important thing to understand about familial hypercholesteremia is that you diagnose one patient, but you actually identify a whole family at risk. And if you remember that first case I showed you of the 63-year-old gentleman with ARPUS who had an MI in his 30s, when we went back into the family, again, this was the work of Dr. Nitika, you can just see how many other at-risk individuals in that family were identified who were not even aware of their risk for this disorder, even though multiple people had had MIs in their family, though it was slightly later in their age. So this concept of cascade screening is so very relevant. And here we also tested the children, and one individual at 19 years also was identified to be at risk. So this whole concept of cascade screening for familial hypercholesteremia becomes very relevant in evaluation of the family. And it's a standard of care to do this after one patient is diagnosed. If genetic test results are not available, it can be done with non-fasting lipid profile. And in children, the age is controversial. There are different criteria in different countries, but essential to say that cascade seaming in children at risk should be done because we've understood that deposition of lipid starts after. Just to complete the talk, this is from the guidelines that Dr. Seema had alluded to. Once you apply the criteria, you make a diagnosis. There are various modalities of therapy that are available. And you also initiate cascade screening with the lipid profile with or without the genetic testing to identify other individuals and not only give drugs, but also do lifestyle modification, which is very important. What I want to bring to attention, I'm not going to talk about this because this has already been discussed, but management of homozygous familial hypercholesteremia. This is the disorder that is included in the rare disease policy of the Ministry of Health and Family Welfare. Therefore, patients with this disorder can receive their drugs through this policy. And to conclude, FH has been known for very, very long, right from 1938, when it was identified to be an inborn error of metabolism, to 1964, when mild heterozygous and homozygous autosomal dominant FH was recognized. And in 1985, when Goldstein and Brown won the Nobel Prize for identification of cholesterol metabolism and the LDLR spectra. But we are aware that we still need greater awareness for early identification, appropriate testing, and management. And I'm very happy to share that we have a project that is ongoing in Gangaram Hospital, funded by the Department of Biotechnology, on the molecular characterization of FH in northern India and its public health application by cascade screening, for which Dr. Seema and Dr. J.P.S. Sani and our colleagues in cardiology recommend. And therefore, I think that we need to spread this awareness to be able to identify patients early and to prevent unnecessary and early. Thank you so much.
Thank you so much, ma'am. It was so insightful. We don't have any questions in the chat box, but I will just ask everyone to please ask something, like if they have questions. I have a few questions to both of you, and I will go ahead asking them. Ma'am, you ended the talk with a public health policy, and I'll start from there itself. Like, what are the challenges of such public health, implementing such public health strategies in India? And how do you think it can improve early detection in India?
I think that first of all, understanding how to read a lipid profile. And I think that's why we started the webinar with that, because that's the key thing. And the minute we are able to understand that what is an LDL cholesterol or a total cholesterol, etc., about which we have to be careful, about which we should become alert. And we understand that if there is one member in the family who has it, you can identify so many more. And actually, I've not, put out the best pedigree. All of them are like that, all of them. And it takes time for public health policies to come in. But I think as physicians, at an individual level, it's like we talk about newborn screening. It is our duty to look into it and do it for whatever patients come our way.
Ma'am, in the same
And
breath, like
actually,
you
the
spoke
other
about
thing
casting.
which I want to talk, which I want to say, Dipanjana, is
Yes,
by
ma'am.
publication. Until we publish, until we understand, and you see this huge amount of data that has come out from the Cardiology Society of India is definitely going to change it.
The
And the fact that,
policies need publication, otherwise nothing
yeah,
more.
yeah,
Absolutely. Ma'am, you spoke about cascade testing as well. This is something which I also face, like when we counsel patients. Many of them are very scared to, even talk to their brothers or sisters and, get tested. And I understand the role of genetic counseling also comes here, or, even the clinician counseling. But how many percent, what is the percentage of people who actually comply, like apart from the immediate family, the brothers, sisters who are a bit elder, Like how much, like I saw that pedigree, you showed that, you were able to test so many people, but many a times, we fail to actually reach out to these people. So what would be your suggestions for that?
I'll tell you the secret of that. The secret of that is to go where the family is. The family will not come. So it's a challenge. The first is, I think, as a physician, to be convinced that this is a preventable cause of early death. And I think that's a huge thing. The fact that we have treatment to prevent an early death. And then, thirdly, we have to set systems in place. I believe that in such a populous country, it's the easiest for us because we have so many working hands. And therefore, we create a system where we can do this, and we'll really have to go to the family. The family will not come because they are okay. They are not sick. So they don't understand it. And that's why we have to go to them.
Thank you, ma'am, so much for that answer. Just, I think there's one question which is there. Oh, no, it's just a question that's answered. Ma'am, another thing that most of us sometimes get also confused is differentiating between polygenic FH with something which is oligogenic or monogenic. So is only genetic testing the way to understand, or there are other parameters or other things which we will look in the pedigree or the biochemical report to understand
No,
or differentiate?
Dipanjana, like any autosomal dominant disorder, it's not, the presence of a mutation is not 100% penetrant. And you could appreciate that from that pedigree I showed of the oligogenic inheritance, that there were individuals there who had a variant in a gene and yet the LDL cholesterol was okay. So we always have to combine. You have to combine. You have to do the clinical, the lipid profile, and the genetic variant. Also, I think the nature of the variant will go a long way, because we know that for the LDLR gene, there are 5 functional variants as to how severe the mutation is and what does it do to the protein. Is the protein absolutely absent? Is the protein partially absent? Is does the protein just not come out of the Golgi? Is the structure abnormal? So there are many things that go into understanding that. So it has to be everything
It's
together.
combined together, I guess.
Mhm, mhm.
When you there are certain times we have done the testing, and then we have the genetics, everything is there. But there are certain cases we face of statin intolerance. So many a times the cardiologists, they, or the biochemist, like who is treating the patient, would come back to us asking that, is there something we can understand from the report of statin intolerance, or should there something else be done genetically? Is there any other
No,
predisposition that needs to be looked into? No.
not that I'm aware of. Not that I'm aware of.
Okay,
I mean,
and
there's
ma'am,
no further testing to be done.
but is there any implication, like have you seen any cohorts of statin intolerance with any other feature or anything, or like it's just that some people are statin intolerant?
Yeah, yeah.
Okay.
I have not seen any genetic association. Not aware of any.
Okay. And ma'am, any role of the newer drugs that are coming in? Like I think there are certain new drugs that have come in, like bempedoic acid or inclisiran.
Yeah, yeah.
Like how relevant are they for the Indian practice?
It is very relevant. In that one slide I showed you of the management, which is there written by the Cardiology Society of India, because they are their recommendations. There is a specific format. You do start with lifestyle changes. You do look at statins first as a start. And then there is a stepwise management depending upon how the level of LDL cholesterol is working. So there is a role for all of these.
Just
And
an
Yeah,
here, Dipanjana, I'd like to
yes,
say
ma'am.
that what they say about inclisiran, especially, which is the small interfering RNA, they say
Yes.
that you have to have reached the maximum dosage of your statin. And when that is not effective, then you go on to inclisiran. That is the recommendation, and inclisiran will reduce it by 90%.
One thing which we often miss while counseling, or we take in not so much into account, is also the lifestyle and the dietary changes. Like, does nutritionists also need to be trained? Because this is a problem which I face in Calcutta, because even if I refer to a nutritionist, they don't know what to do with it. Like, they are not trained enough. So do you feel like we need to train nutritionists also, especially like we have nephrology, we have trained nutritionists for nephrology or transplants and all of that. But with this kind of a thing, we really are lacking as far as resources concerned. So any suggestions on that?
So in our team in this project, we do have one person who predominantly looks into the lifestyle. He's part of our cardiology department. And so, of course, it has a role. And that person has to deeply understand the disorder in order to separately from, the cardiologist who's giving the drugs, give time to the patients for them to understand what is it that we say is the lifestyle modification. So there is a need, and there is a need for that awareness.
I somehow feel that if we have to give good care to the patients, like the nutrition part should always come in. And there's so many reports where it's actually benefiting the patients to like along with the therapies that are being given. So with that, it's already over time, and I'll just ask one last comment from both of you, Professor Dr. Seema, and from you, ma'am. Just one last statement on awareness, and where do you see that?
I just have one question for Ratna. So, Dr. Ratna, you know that we have the cardiology. When a patient comes there, in the follow-up, they have lifestyle management. But when you diagnose a family, at that time also, do you give them a lifestyle advice?
So when I diagnose the family, they're already under the care of the cardiologist.
Okay.
So I just ensure that that bit is looked after. I ensure that the patient understands. The patient only understands the medicine. And that's for any form of genetic disorder. The medicine on its own does not help as much as the supportive care. And for FH, that supportive care is the lifestyle change. The patient will not forget the medicine, the patient will forget the lifestyle change. And so therefore, we always speak with that person that is as important as taking the pill.
Ma'am, we have Dr. Rashid
Dr. Merchant, yeah.
Questions. So, sir,
Good
please.
evening, Dr. Merchant. Thank you for being here.
Good evening, sir. Please unmute yourself, sir, and you. Sir, are you there?
It's muted.
Yeah, no, I reminded him. Sir, I just text him.
So while we are waiting for him, I would like to say one thing, that while we do a lipid profile and we give a report, if we add the risk profiling and the target goals for each risk category, it will actually not only help the physician to treat, but it will help the patient to understand. And as Dr. Ratna said, the moment there is one person in the family who has an early or even any age cardiac disease, they should be seen by their physicians, by their cardiologists, and the whole family should be assessed.
Yes, sir, it's online. Yeah. Sir, please go ahead and ask your question, sir.
Am I not?
Yes, sir, you are audible.
I don't know what's happening.
Sir, you are audible, sir. Sir, you are audible. Please go ahead. Sir actually has texted me the question. I think he's having some trouble. I'll just mention it. He says that which I think statin treatment is better, injection, Ripatha, or azitemim oral. Yeah.
No, we are not the cardiologists.
Sorry, it's not my area of expertise, but usually what I have seen, it's either atorvastatin or rosuvastatin.
And
The
if you muscle, small muscle spasms with that, it's pivastatin.
yeah, the ezetimibe is not a statin. That is a drug that is given if the statins are not effective enough in bringing the LDL cholesterol down. And that I'm not aware of any parenteral statin. Most of them are oral.
No, parenteral. Inclisiran is parenteral, and
not the statin.
not the
Inclisiran,
statin. Not the statin.
PCSK
Sorry.
inhibitors.
Yeah,
The PCSK inhibitors and inclisiran are parenteral.
parenteral, but
Given
not the statins.
subcutaneous. Yeah.
Okay, so sorry, sir. I don't know. There was some problem. So, though you unmuted, you couldn't speak. I did ask the question. Apologies for whatever glitches are there from our side. And thank you, Dr. Ratnapuri ma'am. Thank you, Dr. Professor Seema ma'am, for enlightening us. I sure learned, and thank you so much. It's always a pleasure to learn. And I hope all the 50 people who joined learned too. On behalf of Organization of Rare Disease India, Prasanna sir, Madan sir, and everybody here, my heartfelt thank you to both of you, and also the viewers who joined very nicely every Saturday to us. And next Saturday also we will be coming up with another topic, and this would be something, again, a rare disease topic, which is interesting. And we hope to keep bringing you such topics so that we learn and we learn together and we grow together. So with this, thank you so much, and see you again next Saturday. Thank you.
Thank you so
and
much.
sorry
Thank
for
you,
my
Dr.
absence of a video.
Okay. Bye-bye.
Bye bye.
Bye.
Thank you, Deepanjana.
Thank you, sir.